In glaucoma, the peripheral visual fields are destroyed first, while the central fields last until the end stage. This orderly and predictable one by one loss of nerve fibers is a salient feature and the reason for doing parametry in glaucoma. If the nerve fibers were being destroyed randomly, then the role of parametry in glaucoma would be of no value. Before I discuss the issue of orderly loss, it is important to review the arrangement of the nerve fibers in the retina and optic nerve head. The central vision fibers originate closer to the optic nerve head, lie superficial or closer to the vitreous, and after making their 90-degree turn, they exit from the central part of the optic nerve head. Whereas the peripheral field fibers originate furthest from the optic nerve head, lie deeper or closer to the sclera, and after making their 90-degree turn, they exit closer to the edge of scleral opening. The turn cupping implies that the nerve fibers are being destroyed concentrically from the central part of the optic nerve head and extend to the peripheral part due to the direct action of elevated intraocular pressure. If this was true, then the central field should be destroyed first and the peripheral fields at the end, according to the arrangement of nerve fibers in the optic nerve head. But in actuality, the peripheral fields are destroyed first while the central fields last until the end stage of glaucoma. This fact alone would reject the cupping theory which was mistakenly given 170 years ago. The accepted normal range of intraocular pressure is from 10 to 21 millimeter mercury. The elevated intraocular pressure, even acting alone, is an established cause of glaucoma. For example, in unilateral traumatic glaucoma in healthy subjects, the intraocular pressure is the only risk factor present. This confirms that elevated IOP acting alone would result in glaucoma. However, the elevated IOP by no means can destroy the nerve fibers one by one in the densely packed optic nerve head in an orderly sequence by its direct action. This creates a very puzzling question in glaucoma. If elevated IOP cannot cause the orderly loss of nerve fibers by its direct action on the optic nerve head, then how is the elevated IOP causing the orderly loss of nerve fibers? In fact, there is no biological process which could lead to the orderly loss of nerve fibers. Only a mechanical scenario can achieve this goal. Then what may be that mechanical scenario? It appears that elevated IOP must be destroying some important component of the optic nerve head first, which would then lead to a mechanical process for the orderly one by one loss of nerve fibers. In other words, glaucoma may be a two-stage disease. The first stage is a biological stage in which there is degeneration of the border tissue of Elschnig due to elevated IOP. The border tissue is supplied only by the ciliary circulation, which is a low pressure circulation. The central retinal artery, which is a high pressure circulation, does not contribute to the border tissue. The circulatory pressure of the border tissue is around 25 millimeter of mercury, which is higher than 21, the upper limit of normal IOP. Normally, the circulatory pressure of the border tissue should be higher than the IOP for its proper perfusion and healthy maintenance. However, if the IOP becomes higher than the circulatory pressure of the border tissue, it will start compressing the border tissue circulation, resulting in chronic ischemia and its degeneration. Conversely, if the circulatory pressure of the border tissue is reduced, say to about 15, in subjects such as those with chronic hypotension, then even a normal IOP of 16 will act as elevated IOP, leading to compression of the border tissue circulation, resulting in its degeneration. This would be an example of normal tension glaucoma. Due to the degeneration of the border tissue, the lamina cribrosa would start sinking in the scleral canal. The sinking of the lamina cribrosa initiates the second or mechanical stage. Due to sinking of the lamina cribrosa, the deepest nerve fibers belonging to the peripheral vein would be stretched and severed first at their 90-degree turn against the scleral edge. As sinking of the lamina cribrosa progresses, the next in line fiber would move to the scleral edge and gets severed. More the nerve fibers are being severed, the deeper the lamina cribrosa will sink due to loss of anchorage provided by the nerve fibers. This cascade of the sinking lamina cribrosa and severance of nerve fibers would continue until the centralmost nerve fiber has moved to the scleral edge and gets severed. At the end stage, the sunken lamina cribrosa is totally empty of nerve fibers. The degeneration of the border tissue of alcyonic appears to be the key factor in the pathogenesis of both high and normal tension glaucoma. Sinking of the lamina cribrosa and severance of nerve fibers is able to explain the orderly peripheral-to-central field loss in glaucoma. In summary, glaucoma may not be an optic neuropathy, but an optic disc axotomy, a paradigm shift.